We thank all the three speakers, Dr. Shanmugh, Dr. Sridhar, and Dr. Satish, for their very good lectures. I'll start off the discussion with Dr. Satish. We find the treatment of idiopathic hirsutism more challenging. That is, after OCPs, if they are not responding, we might have to start finasteride. Yeah. How long it is safe to give finasteride? I mean, the duration both for OCPs and finasteride.
Usually,
the safety data. That's the
6 months is advised before going on to challenging them with finasteride.
Finasteride. Okay. Thank you. Floor is now open for questions.
Question to Dr. Sridhar. What is the risk of growth hormone therapy to the, if you start early, to the premature fusion of the epiphyses?
Pardon, sir, premature?
What is the risk of premature fusion of the epiphyses to starting the growth hormone therapy in early stage? Very early. Means you're starting very early therapy. Is there any chances of premature fusion of epiphyses? Is there?
No, if unless the gonadotrophin is essential for the fusions or closure of epiphyses. So if there is we can start, but commonly we used to see or start after some 2 years of age. But many of the time we may used to see around 3 years or 4 years, even though there may be a congenital onset or multiple growth hormone deficiency. So we used to wait till 2 years at least, but there is no definite point of time. But since if you delay the puberty, then is no contraindication. Once advanced or if associated with the early puberty, then chance of fusion, this thing is there. But many of the times the bone age is more than 13 years or 14 years, then maybe we may not expand that much amount of response. And so it's basically individualized rather than.
Question to Dr. Sridhar. How long do you give growth hormone?
So there are some 3-4 cutoffs are there till the age of puberty, or the bones are fused, or the growth velocity at 2 consecutive years are less than 2 centimeter per year. So predominantly till the age of puberty we used to give at least 14 to 16 years. Otherwise there is less than 2 centimeter per year. But even in Western countries they used to continue even adult. But the dosage are different in adult growth hormone deficiency, not for the height benefits, it is for the metabolic benefit. So to improve the body stature, protein metabolisms or other for non-growth benefits of growth hormone.
This is a daily regime.
Daily, but in some phase 3 or phase 4 trials are there. Once weekly, we may expect in future, but how yearly we don't know. But once weekly in phase 3 and phase 4. So in future we may expect once weekly growth hormone therapy, but we need more data to prescribe or suggest.
Then you have to give daily injection for 14 years.
So if it's starting, otherwise if financial this thing is there, in between also we can stop and we can assess. But if you give continuously, then response is going to be at physiological rather than intermittent therapy. So once we started, at least one yearly there should be an continuous. Then only we can assess the response. Intermittently, if they are putting growth hormone, then no point of using the injection.
So I must congratulate all the speakers for this excellent exposition. To Dr. Sridhar, now your topic is on optimization of growth hormone. As one of the chairperson has told that using growth charts is a very essential one. And also it's very important that we use Indian growth charts, not the CDC or WHO growth charts. Now the importance of optimization is that some of these children, they don't have the appropriate growth with the set dosage. Now, there is a problem. So, in all these patients, they don't respond to a 0.3 milligrams. Now, in those conditions, we must rule out any associated endocrine problems, infections, nutritional deficiencies, and chronic infections. So, that is very important that we must keep in mind. And he also highlighted in the slides when to stop the growth hormone therapy. That is very important. So optimization, sometimes you won't find that amount of adequacy of some of the people, they may require a higher dose of growth hormone. Now that is why now they wanted genetic testing for growth hormone deficiency. Some of these people, children, they require a higher dose of growth hormone. So there are a lot of vagaries involved in the optimization of growth hormone. Now, Dr. Satish, usually we see lot of people with hirsutism, mostly in our setup, we have polycystic ovarian disease. Now, the commonest investigation that we do is TSH, prolactin, and testosterone. So, I think that initial investigation, we must do a thyroid function and prolactin estimation. And you advised transvaginal ultrasound, but that is only for a married person, because many times unmarried girls come with hirsutism. So they must not do a transvaginal unmarried girls. And also the dose of spironolactone, one Dr. Amini has done, she has done in 50 milligrams of spironolactone for Indians. So I think 100 to 200 milligrams, I don't know how many people will be using 200 milligrams. It's quite high.
Thank you, sir.
Thank you so much, sir, for a great session. So now it's time to felicitate the speaker and the chairpersons. May I request Dr. Sendil to felicitate Dr. Shanmuga Sundar by presenting the memento. Next, Dr. G.D. Karthikeyan to felicitate Dr. Sridhar by presenting a bouquet. Next, Dr. Balu to felicitate Dr. Satish Kamalanathan by presenting a bouquet. Audience can give a claps. Thank you. And may I request Dr. P.G. Sundararaman sir to felicitate the moderators, Dr. Sendil, Dr. G.D. Karthikeyan, and Dr. Balu. Thank you so much all.